RAS, renin, angiotensin, aldosterone system. Okay, so listen to those words. So you're right. So when you break these out, and I'm kind of doing it the way when we talk about it this way, your RAS, what do they say? RAS suppressants. So these mess with the RAS system. ACE inhibitors. Okay. Huh? Yeah, they're inhibiting, exactly. So what did the ACE inhibitors end with? Krill. So the prodrug that ATI likes is captopril. Okay. Krill is the key ending. Everything in krill, lisinopril, captopril, blah blah blah. That's your ACE inhibitor. As far as ATI is concerned, that's a RAS suppressant. Okay. Think about the RAS system and how it works. What else did we talk about in that system? And in Sartan. ARBs. ARBs, right. So ARB. So you know what they use for this. So losartan is what they go with. Losartan. Sartan. So what does ARB stand for? RAS system, right? Close. Receptor. Blocker.
Angiotensin receptor blocker.
Remember, angiotensinogen 2, then it jumps onto that receptor, and that's when all the things happen. So you're blocking that receptor. Okay, so those in your in sartan, ATI likes low sartan. That's the one ATI likes. So this one will be fun. Let's look at this part, aldosterone. Remember about aldosterone, what it triggers. Fluid retention, right? Because if you remember the RAS system, when you have certain things that trigger it, your sympathetic nervous system, hypovolemia, hypotension, things like that will trigger this. One of the things your body's going to do is to increase, if you remember your cardiac output, right? You have heart rate, you have stroke volume. Stroke volume, you have preload, contractility, and afterload, right? One of the things it's going to do is it's going to increase volume. That's going to increase pressure, and it's going to increase preload in the heart, and it's going to increase afterload as well. Okay? Aldosterone, if you block it, so the way ATI likes to talk about it are aldosterone, what do they say? Antagonists. Okay, aldosterone antagonists. If you inhibit that process, you're not going to retain fluid, right? You're going to spill more sodium, keep a little more potassium, things like that. All right, so if we're working on this, you guys will recognize this. The two that they talk about for aldosterone antagonists, one, spironolactone, right? So that's where it works. Whereas furosemide, hydrochlorothiazide, those work in the kidney. This works in the RAS system. And the other one they talk about is eplerenone. But again, right? Spironolactone, eplerenone, those are going to work as an aldosterone antagonist. So think about that when we're talking about.
I'm lost. I'm lost.
Okay, so what are you lost about, right? We're talking about RAS suppressants. That's what ATI talks. That's the way they talk about it. If you look up here, you have an angiotensinogen that's produced in the liver. If you have stress, if you have hypovolemia, if you have hypotension, things like that, your body wants to compensate because your kidney needs to have a certain amount of volume, needs to have a certain amount of pressure in order for it to function normally. It's like 25% of the volume, so it's kind of a hog when it comes to organs. So anything that happens in the kidney where those things are happening, if you kicks this system off.
Okay.
If you think about high blood pressure, one of the reasons we have high blood pressure is because of stress. One of the things stress does is it kicks off this system.
It turns it on.
Turns it on. Yeah, turns it on. So your body, because you're stressed, your body needs more cardiac output, right? And so because your body needs more cardiac output, one of the ways that your body thinks it can get it is by turning on this system, your RAS system. Okay?
And
So
it's trying to get it from here instead of, it's
Well-
compensating, trying to get it from this system, the RAS
Yes.
system.
Yes.
Okay.
Yes, exactly. Otherwise, we'd have to give volume, or we would have to give some other
Okay,
type
and then
of
when
medication.
it kicks this, then we use an ACE inhibitor and an ARB to level it out.
Yes,
Okay.
or to trick it into not starting. We're
Okay.
saying, we don't need you.
We
You're
don't need-
stressed out.
okay.
We don't need that extra cardiac output. We don't need this whole thing taking place. So we're going to block it at different places. So ACE inhibitors, captopril, for example, you're going to block it up there. If you block the ACE inhibitor from working, this doesn't happen. If that doesn't happen, none of this other stuff is going to happen. Okay, ARBs, if you look at the ARBs, that's going to block the actual receptor so that that cannot work. So it's just a different way of futzing with this system.
So the
Block the
ARBs,
RAS
Turning it off.
system.
the ARBs goes lower into the process then?
Yeah, it goes to the receptor level and
Okay.
it blocks it.
Okay.
Okay, now aldosterone. So again, aldosterone typically is secreted. You don't want it to be secreted because that's where you get extra volume, and that's where you get, normally potassium. If it's secreted, normally potassium gets held back. Sodium gets dumped out. It gets held back, so you get volume, right? Because volume follows salt.
And then
We're blocking that.
So when we give an aldosterone, it just doesn't increase the fluid. It's
It
like
gets rid of it.
spironolactone, it just gets
It
rid
gets
of
rid
it.
of it.
Okay.
It's just a different mechanism of working. And so that's where spironolactone comes into play. That's our potassium sparing diuretic, right? Because you're messing with this piece with the aldosterone. That's why it's sparing. It's telling your body, don't kick out potassium. Just kick out the sodium and the water.
Okay. now-
Okay? So those are your two, does that help?
Yeah.
What was the last one, Thank you.
Yes. We will titrate pressors to MAP, or not pressors, we can, to a certain MAP, mean arterial pressure. And that is the pressure that your kidney needs in order to work normally. So a lot of times, as practitioners, you use a MAP in order to make sure your kidney's getting what it needs. Think of an ICU setting, a critical care setting. If you have a patient that's, having issues, they're hypovolemic, or maybe they've had something done and they're hypotensive, you want to have the kidney function normally, right? So you're gonna give medications, you're gonna give a pressor usually to keep the MAP at a certain level. So that's what Haley's talking about. But yeah, that's all really good. So again, when you're thinking blood pressure, there's lots of reasons why you're gonna think cardiac output and such. But, okay, so this is one of the big areas too. So beta blockers, right? They don't work in this system. ATI likes to talk about it in terms of, what do they talk about? Sympatholytics. So think of the sympathetic nervous system, right? So ATI likes, think of the different receptors you have in the sympathetic nervous system. Two main ones, right? Two big ones, alpha and beta receptors. So when we're working with sympatholytic, what does that tell you? Lytic. No. Break down. So these are antagonists, right? We're blocking that system. We can block it in a few different ways. So ATI, they have the alpha 1, which is your doxazosin, right? That one's used for BPH, because it's a dilator.
I'm so sorry, I just cannot read the handwriting. It's just, I have bad handwriting too, but it's not making a scribble.
Let me see if I can, dogs, and make sure I spell it correctly too.
What is the word before it?
alpha 1. So that's an alpha. So basically it's an alpha blocker. So all of these are going to be blockers because they're sympatholytics. So doxazosin, can you read that better? And if you, you know what I'll do? Let me copy this. The beta blockers, yes. Yep. So these are the two ATI lights. They're prototypes, but carvedilol is also a beta light, but carvedilol is a combo alpha beta. So these are beta blockers. You're centrally acting. So you remember when we talked about centrally acting. This is one of the agonists, so this is a little different. That one is your clonidine. Okay, clonidine. So clonidine is one we talked about in the quiz last week, right? This is one, where do you give this frequently? This one is methyl-dopa. Yep. And it's an oral medication you see it used in clinics a lot. So clonidine is another. So this one works by agonizing your alpha 2, which is a little bit different. Okay. Kind of doesn't fit under some type of regular. Then you have your alpha betas. Alpha beta blocker. That's carvedilol. Carvedilol. So this one you'll use. Now think about, we talked about beta blockers and when you don't want to use them, right? Do you remember what patient population you don't want to use a beta blocker in?
Elderly.
Huh?
Elderly?
No. Huh? So, respiratory issues, people that have COPD, bronchitis, asthma. Because if you're giving one of these,
Does it suppress the respiratory system, or what does it do?
if you remember, what do beta receptors in the lungs do when they're stimulated by the sympathetic nervous system? They dilate, right? Think fight or flight. You want your airways open
Lungs.
because you're rock and rolling. If you're blocking that action with a patient that has COPD or something like that, you can cause vasospasm. Especially if it's a non-selective, non-cardio-selective, which that one would probably be a non-cardio-selective, right? What part are we controlling on? So think back to our cardiac output up there. What are we controlling in here?
Controlling the force and pressure.
How?
Like that's for the sympathetic nervous system.
So you're causing essentially dilation, right? And you're also changing cardiac output because beta blockers in particular, what do they do to the heart rate? Slow it down, but at the same time, they impact contractility because they're inotrope. So there's lots of things going on with these drugs.
I have a question.
Yeah. MIs. Although let's talk about vasodilator real quick. That's another one of the things we're going to talk about. So vasodilators, strict vasodilators. So let me get a little slide picture up. That way you guys can see it. Again, we're messing with pipe.
What's your sugar, sorry, is it trillium and where's
Efferone. Efferone. So, vasodilators. So you can look up there, they have some up there, easier for you. Okay, vasodilator. So when we're thinking about cardiac output and these pieces, what are we messing with? Messing with the pipes, right? So that means you're going to be messing with systemic vascular resistance. Okay, you're going to be messing with afterload, because that's where we dilate things. So up here you can see that you have vasodilators. So some of the ones we use for high blood pressure are hydralazine and nitroprusside. Nitrates, this is a big one, right? Nitrates, think about, so let's see here, let's put the these up there. Some of these fit into multiple categories. Nitroglycerin. Can you guys read that, nitroglycerin? What do we give nitroglycerin for? We talked about it. Chest pain. It's an anti-anginal. It's also a vasodilator, so it does mess with the systemic vascular resistance. But this in particular is a coronary artery dilator. So one of the reasons we give this, you think about MIs. What's happening in MI? Myocardial infarction. What's happening? Narrowing. Huh? Well, you do have that because of the damage that's happening, but ultimately, for whatever reason, it could be narrowing, it could be a blockage, it could be you're not getting oxygen to the heart. Ischemia. That's the root of MI. Okay? There's lots of reasons why your heart's going to get ischemic. You guys talked about a few. You might have plaque that's built. You might have narrowing. You might have a full-on blockage. Depends on where it is. Anything past that that is not getting oxygen, that's when you start to feel the pain. So your heart doesn't have pain receptors like, if you cut yourself. It's different. Your heart, when it's feeling unoxygenated or has that ischemia, it tells you in different ways. You get that pressure, you get that pain shooting into your arm. Women, it's in the back. They present with back pain more. So that's your heart saying, hey, there's something going on. Okay, but the root of it is it's not being oxygenated. One of the reasons we give nitroglycerin is because your coronary arteries, if there's a blockage or if there's a narrowing, makes them bigger, right? It helps get oxygenated blood around that spot to oxygenate the heart. So that's why we give nitroglycerin frequently for chest pain. Now, with MIs, you are also going to give beta blockers, okay? So you've got nitro, and that's a bummer. Nitro, you give beta blockers. Why do you need to give beta blockers? That's one of the things. Yeah. Basically, when you're having an MI, or your heart's freaking out because it's not getting oxygen, it releases norepi, epi, all those sympathetic neurotransmitters, because it's your heart stressed, right? You don't want all of those things kicking off. Epinephrine, norepinephrine, dopamine, what do they all do? They increase cardiac output, right? Increase pressure, increase heart rate, the squeeze. Now, if you have a heart that's not being oxygenated, and your body is saying, hey heart, we're stressed. I need you to pump faster and harder. What's happening over here? Because they're already ischemic. You're going to get more ischemic, right? Because that demand, there's this oxygen, there's this little demand for supply and demand, big supply and demand, right? The supply of oxygen to your heart is decreased because of whatever reason. But the demand has just shot way up because of all those catecholamines. And so your heart's going to be like freaking out even more. They become more ischemic. Again, your heart is greatly compensated, but also not great.
So physiologically, is that like your heart trying to dislodge something, or why would it be acting?
It's not really trying to dislodge something. It's just saying my cardiac output, I'm stressed because my heart is not getting oxygen for whatever reason. Relaxing, right? Mona, that whole thing, oxygen. You need oxygen because you're going to overdo it on the body. I mean, you're going to get a whole bunch of oxygen in the body, so that hopefully you'll get a little more where it needs to go. Heart muscle. But what happens when heart muscle dies? It's done. It does release certain enzymes like you guys were talking about, but it dies. If you have heart muscle that is ischemic for long enough, not getting oxygen long enough, then that takes us over to heart failure. Okay? So a lot of times, there's a lot of other reasons why you have heart failure, but if you have a large portion of your heart that is ischemic for long enough, that's gonna die. That muscle dies, it's gone. You can't fix it. And so if you have enough that dies, then you're gonna start to see impacts overall in the heart, in the beating of the heart, right? So, nitroglycerin, we're trying to open up that coronary artery to get blood back there to help with this, right? We're gonna try to get oxygen where it's not going, so you minimize damage to the heart. You need a beta blocker. That way you block all those catecholamines, which is gonna increase that demand on the heart, which your body being dumb, unfortunately, but it's still compensating. You've got that demand that's gone way up, your beta blockers is gonna help block that. Okay.
Does morphine do vasodilate as well?
So morphine, it doesn't necessarily do vasodilation, but what it does is it helps with pain, which is gonna be contributing to the sympathetic fight or flight response.
So it like
Right.
calms you down.
So it's gonna calm you down, it's gonna help with pain, it's just slowing things down, basically, and it's pain. Because you're having a lot of pain when you're having an MI, right, in however it's manifesting. And a lot of people, they'll feel like they have an elephant sitting on their shoulder. There's lots of ways it's been described. So that morphine's gonna help with that, calm down, right? Oxygen, you gotta over-oxygenate the body to compensate for that area, and hope that, you know, you get some oxygen in there. But these are biggies you're gonna give for MIs. The other thing to do with these patients is they need to get to the hospital if they're not there. They need to get to a cath lab right away, so they can figure out what's happening. Then they can do an angioplasty, they can put stents, you know, if it's bad enough and they can't do anything, open heart surgery, right, you've gotta get blood flow back to the heart. That's all there is to it. And so that's where your MIs come in, that pain, angina that you're feeling from heart stuff. It's just, there's no oxygen, for whatever reason. Now, we'll talk about lots of reasons why you would have it, right? High cholesterol, you take drugs to reduce the amount of cholesterol so that you don't continue to get blockages, right? Your arteries don't continue to narrow. Vasodilators, you know, they may be on nitroglycerin for maintenance to keep all of those open longer. So, vasodilators, these we use, but again, when we're talking about MIs, because that's one of the big things you guys are going to be encountering. You know, nitro and beta blockers are biggies, and then other vasodilators, other things for pressure. Right? You're going to be using a combination of things. And it depends on where you're at. But with MIs, time is of the essence. The quicker you get them to the cath lab, the quicker you can open these arteries, less damage your patient's going to have. So about 20 years ago, my dad had an MI. And it was at 3 o'clock in the morning. 3 o'clock in the morning, you know, he woke up and felt weird, you know. My dad would run like 5 miles a day. He was gonna do that all. Get that opened up so that that blood gets around, in this case, around whatever's causing the blockage, narrowing, or whatever. So, heart failure. Let's say, we'll just take this little path on down. You have heart failure. You have enough muscle tissue, heart muscle tissue that's dying, okay? Now, we're talking heart failure. Heart failure has a whole bunch of different, different ways you see that. You can have, one of the things we talk about is ejection fraction. Do you guys know what ejection fraction is? You probably heard it.
It's when your heart doesn't ever pump 100%, but your regular ejection fraction should be between 55 and 60, and if it's below 55, then you're headed down into heart failure. If you're at 45 or lower, then you're more screwed.
Yeah, so basically, yes.
Basically.
Yeah, basically, ejection fraction is the amount of blood your heart is pumping out each time. Okay, so when we're talking about, you have a lot of muscle tissue death, say in the left ventricle, right, for that matter, your EF is going to be lower, right? Because your heart's like, ugh. It doesn't have that same squeezing capacity. And so, this is where we jump into some different medications, right? Well, I don't know, let's go. When you've got enough muscle that's died, for whatever reason, that's one of the ways. Another way you could have reduced ejection fraction is if you think about patients that have chronic hypertension, what's our heart doing? It's working hard, right? Your heart is a muscle. The muscle, you normally, no pain, no gain, right? You work hard, you get big muscles, whatever. But in your heart, if your heart's having to work so hard that it's building muscle, which will, it'll get bigger, you will decrease the amount of ventricular space that can hold blood. Because you've got this thickened heart wall. It's gonna be less because you have less volume that you can need to push out, because you've got a bunch of tissues, you've got this thick wall. And so that's another way, that can be caused by not managing your hypertension very well. Either way, you've got low ejection fraction. So your heart is not, the stroke volume out of your heart, cardiac output, right, is not what it needs to be. So we're gonna give medications like digoxin, that's gonna help with that squeeze. Dopamine helps with squeeze. Now you wouldn't necessarily, you'd give that more than ICD type 7, but digoxin is one you can take longer term. That's the cardiac glycoside, just like we have up there, right? But also think about your inotropes, think about diuretics, okay? You're gonna give diuretics, why? Fluid. Your heart's not pumping the way it's supposed to. It's not getting to the kidney like it's supposed to, and it's just kind of, sitting there. So you get this fluid overload. Now, think of our little cardiac output thing, right? Volume is one of the things that impact pressure, one of the things that impact your heart, because if you have a whole bunch of volume getting dumped into your heart, it's already weak, it's not gonna help out, right? So one of the ways you manage that, both pressure, and so both preload and afterload, is to get rid of volume. So we're gonna use our diuretics, right? Think of our, I don't have my other diuretics up there. So you've got your Lasix, your muscles just can't handle it anymore, so you're gonna be helping the heart and the inotropes to make it squeeze better, diuretics, plus the other thing you're gonna be messing with is SVR, right? Because that is part of what that heart has to push against. So remember, think back to that diagram. That diagram is gonna be your friend through all of it. Adult health too, whatever, because it's all kind of tied in, right? So you're also
give a beta blocker, right? You'd also give the part beta blocker.
You can, yeah. Now that one you have to be a little bit careful with, because it does decrease heart rate, so you have to be a little bit careful. And one of the reasons we give it right after an MI or during an MI is to block the catecholamine cascade that's happening. Yeah, you can still give beta blocker, because it is an inotrope, right? No, it's not an inotrope, it's a negative inotrope. So you really be very careful when you get beta blockers for heart rate, because it's kind of
It was different because working in a heart failure clinic, we hardly ever gave digoxin. We gave more carvedilol and then a diuretic and then whatever blood pressure medication, but hardly ever did we give digoxin.
Yeah,
That was like a last resort.
Yeah, it kind of depends on where you work. We decide digoxin certain therapies for patients that are on the heart transplant list. Now, if you're on the transplant list, does that make sense? There's lots of reasons why you have heart failure, not just because of the MI, but that's one of the ones where if you have this, you can help prevent that by getting the cath lab right. So it depends on where you work. Yeah, you can have cardiomyopathy from drug abuse, absolutely. Endocarditis, that one you can take orally. So Milrinone you can put over here. That helps with pressures because it's a dilator. Nitrates, cardiac glycoside. Okay. Any questions on this?
We're gonna have to know, I haven't really looked at the study guide yet, but.
We talked about that. Minoxidil, it's a little bit different. So again, when you guys are looking, if I have these drugs on your study guide, you're not being an expert, right? So between the slides and this book, okay, you guys should be fine. But I put the drugs you need. Nitroprusside, cyclodrazine, talked about angina, we talked about ischemia. Here's a little graph in there, way better than mine, but it talks about the oxygen demand for the heart. So, yeah, we kind of talked about this. So, how does the, let's talk about this real quick. So, when does your heart oxygenate? Yeah, on systole or diastole? Huh? Diastole. So this is just a little bit of fun stuff. Any questions on this? Drugs, vasodilators? No? You good. So, your heart. Let's see here. Let me do my little heart picture here. Okay, so here's your heart, right? So, think about where, so diastole is when your heart gets oxygenated. What happens is, if you think about it, when your heart contracts, it's pushing blood out the aorta everywhere else, right? There's a little flap, and I'm not a very good one. I can't really draw that. That looks like a pumpkin. You have a flap. So the opening to the coronary arteries is off the aorta. Whenever you squeeze the heart for systole, so when it's contracting, there's a little flap that covers that hole. So the blood goes out into the aorta to the body, right? When you're in diastole and it's relaxing, that little flap pops down, and then basically the blood drains back into the coronary arteries and on down. So there's lots of different things we can do with this. When we're talking about MIs, in particular, when we're talking about certain things going on, there are ways we can help with coronary artery perfusion. You guys know what a balloon pump is? So a balloon pump, you know, has anybody ever seen a balloon pump?
I have.
You have?
In the ICU.
Yeah.
Where the doctor just puts it in when they come out with like open.
You can.
They have like a metal rod and they pump it like when they're coding.
Oh, so this is a little bit different.
Oh.
So you have balloon pumps. Huh?
Are you talking about when they stop the bleeding?
No, I'm talking about to help with coronary perfusion. So
It
you have
goes in and then they open it up like that.
yeah, basically they're going through the femoral artery, comes up here, and it's literally a little balloon that kind of sits in the aortic arch. And so for sick hearts, you know, maybe you've had heart surgery, maybe the patient has had heart surgery, or they have some reason that they need to rest their heart. You want to reduce that workload, right? So they'll use one of the things is a balloon pump. And so they'll go in through the femoral artery, they'll go up into the aortic arch, and it's a little balloon. It's like this long. It really looks like a condom. That's what it looks like. It's very thin, and it opens and closes. Okay, and you can set them to do it every beat, or you can do it every other beat or every third beat. And so what that happens when that balloon pump deflates, what's happening? Just think. Right, and it's kind of creating a suction, right? As that balloon pump deflates, theoretically, it's going to deflate at the same time your heart contracts, because your heart's going to be pumping blood out. As it deflates, it's going to kind of suck it out, right? It's going to kind of pull it out.
And how does blood get around, like, the blood?
It's very, right? Because your heart's, for whatever reason, just not working like it's supposed to. So you're just kind of helping it out. These are temporary. You wouldn't keep them in there for very long. But it does help with that. And so you might be managing the patient that has a balloon. It's kind of cool. It's kind of cool. It's kind of cool.
How can you visualize like a balloon pump like that, like from the outside?
So you would have to use X-ray or everything.
So an X-ray could be on the outside.
Yeah. So like if you've got a chest X-ray, and sometimes they will do that just to make sure placement is okay, you'll see the little, because they have a line, you'll see a line. You're not necessarily going to see the balloon, because it really does look like a condom. So it's real thin, but it's like plastic. It's probably not. But it's real thin. You can still see it on an x-ray, you can see the line on an x-ray. But you might see that in impella. Have you guys ever heard of an impella? So these are ways to help the patients whose hearts are failing. They're non-medical, non-drug. So an impella, a little different than a balloon pump.
What's it called?
An impella,
Can you help like the car?
that's an impala. That's an impella. Yeah, IMPELLA, impella. Basically, same type of thing, it's gonna go up through the femoral artery, and it's gonna have this little pump that goes into the left ventricle and into the aortic arch. So it kind of goes through the valve and sits there. And what it does is it acts as a pump. It's like a little pump. And it will pump blood from the left ventricle out through the aorta to the body. And so this is another thing you guys might see to help that heart, because it's not beating like it used to. You just need it to rest, right? You want that heart to rest. Maybe they came out of heart surgery and it was, the heart didn't wake up
So
as
when they
well.
come out of heart surgery and the patient codes, what was the doctor doing then? When he like said he was gonna basically, and then they like had him, his whole chest open, they didn't, he was floating right there and they like did something to him. What were they doing?
Well, let me think here.
Yeah, he came out of
So I don't know. It
open
depends. I
heart
mean,
surgery,
okay,
came
so if he,
out, still had a rod in,
okay,
and
so
then
he was open still,
yeah,
and
coded.
so his heart stopped.
The doctor went in,
Okay.
they said they're gonna place the balloon and then like he said, they were saying like,
So
pump,
maybe,
pump.
so maybe it was something like this. I don't know. The times that we had patients code after heart surgery, we didn't do anything like that. We would open them up and then we would just use our hand
Oh,
to pump. So I don't know.
wait, you were like,
Yeah. You
Very
literally,
Grey's Anatomy. No, just kidding.
Yeah, I was getting that vibe too.
yeah, so I don't know what pump they're talking about, because the times we had, and you have to be careful with heart patients that code right after heart surgery, they have wires. You can't just jump on their chest like you would somebody
and
else.
start, yeah.
Because if you start on a patient that has a cracked chest with wires, you can rupture sutures, there's all kinds of little things you can do. I had a patient, it wasn't the one patient, but a patient of mine at the heart hospital, came out, she coded, this was probably 4 hours post-surgery, and you have to ask, I mean, there's a way of doing CPR on a patient that has had open heart surgery. It's a little different. You don't go to town like you would on, us. But you have to get the provider's permission before you can start doing that, because you can cause damage. And he just happened to walk in, and we said, she's coding, do you want us to do CPR? Because, and he was like, yeah, start it. And I was the one starting it, and it just went downhill. We ended up taking the wires out and doing manual compressions, basically, on the heart. So you literally squeeze the heart. I got to be the one squeezing the heart, and as I was squeezing it, I could feel the blood hitting my finger on the backside of the heart, because she had a huge hole in the backside of her heart. I don't know if one of the sutures ruptured, but her volume, I mean, we would put 2 units of blood in, and I could feel it get better, and you could see her pressure get better, and I could feel, like, every time I'd squeeze it, I could feel the blood leaving, and so, yeah, so you have to be really careful with that.
So did she die, or?
And,
Yeah, so did that then.
She did. If you're opening somebody's chest bedside, because they've coded, because they've had open heart surgery or whatever, the prognosis for when that happens, for survival, is pretty low. There's lots of moving parts going on in that situation. She died.
So what are the wires for?
To keep your pharmacological, that would help with heart failure patients, right? Or after surgery, you might see balloon pumps, impellas, things like that. They have all kinds of really cool therapies for patients with heart failure now. AFib, things like that. We didn't talk a lot about AFib, but that's very common. We'll talk more about AFib when we talk about the hematologic system, when we talk about anticoagulants, antiplatelets, things like that, which will be next. So let's take a break. Come back at